Hi there, it's Dave here from Arthritis New Zealand, just with a re-recording of our webinar on rheumatoid arthritis. Our initial attempt had some sound issues, so better luck this time. This is what we're going to be looking at today. It's rheumatoid arthritis, or sometimes abbreviated to RA. So what is it? It's a form of inflammatory arthritis. So clinicians tend to categorize arthritis as either non-inflammatory arthritis, which includes osteoarthritis, and inflammatory arthritis. So rheumatoid is a form of inflammatory arthritis, and it's an autoimmune disease. So autoimmune conditions like rheumatoid arthritis and lupus and type 1 diabetes and celiac disease, these are all abnormalities in the immune system. And what can happen is your immune system can start to behave abnormally and start to attack your body's own tissue. So your immune system is there to protect you from things like infections. But in cases of rheumatoid arthritis, your immune system is behaving abnormally and causes problems. Probably the biggest the most important thing for people with rheumatoid arthritis is they get referred to a rheumatologist, who's a specialist who looks after a range of conditions, including rheumatoid arthritis. It's really important. Probably the most important thing is that people's symptoms are recognized, and a GP will make an early rheumatology referral. So looking at some facts and figures, it commonly occurs between the ages of 25 and 50, although people can get rheumatoid arthritis younger than that and also in the older age group as well. Women are 3 times more likely to be affected compared to men, and smoking increases the risk of rheumatoid arthritis as well. So what causes rheumatoid arthritis? Well, there's probably a range of ideas out there. It's not entirely genetic. Obviously, there's a genetic link because it does tend to run in families, but what we do know is that sometimes with identical twins, one may have rheumatoid arthritis and the other one might not. So it's not entirely genetic. It might be influenced by environmental factors, and possibility it might be linked to infection and obesity as well. And I'll put a little number there alongside the obesity because there's a reference at the end of this to show where I got that information from. So it's quite common for people with rheumatoid arthritis to have problems in the smaller joints, particularly the joints in the hands and the feet. So it tends to be the knuckle joints and the wrist joints, and can be symmetrical. So that means that the problems on your right hand side of your body are the same as on your left. It doesn't always manifest like this. So some people can have asymmetrical arthritis, but this is quite common that people get symmetrical problems. So those are the joints there which are commonly affected: shoulders, wrists, knuckles, knees, ankles, and joints in the feet, but people can get rheumatoid arthritis in other joints as well. This is just a slide to try and show the difference between a normal joint, or a joint with osteoarthritis, and a joint with rheumatoid arthritis. You'll see the joint with osteoarthritis, which is a condition which causes changes in bone and cartilage. It's more of a mechanical problem, if you like, where you lose some cartilage, or the cartilage changes and the bone changes and can cause stiff, painful joints. Whereas rheumatoid arthritis is more of a inflammatory condition, causes lots of inflammation around the joint, and if left untreated, can actually cause permanent joint damage. So some symptoms of rheumatoid arthritis: pain, joint pain normally, early morning stiffness. So lots of people with osteoarthritis feel stiff in the morning as well. But people with rheumatoid tend to feel stiff for more than 1 hour. It persists for more than 1 hour. Swelling and stiffness in the joints. Sometimes people get rheumatoid nodules, which appear as lumps, sometimes in the hands, feet, and elbows, and other areas of the body as well. Because rheumatoid arthritis commonly affects people's hands, it can cause lots of issues with loss of dexterity and weak grip. can make lots of things hard to do. And the symptoms can come and go. And sometimes people will describe these as flares, where the symptoms become really a big problem. And then what can happen is the flares can seem to die down. So you get this pattern of flaring and things going a bit quiet. And that can be frustrating, particularly if you're seeing a rheumatologist regularly, because what can sometimes happen is you have a flare in between appointments, and then by the time you get to see your rheumatologist, things seem to calm down a little bit. Some more symptoms of rheumatoid arthritis: lack of energy, loss of appetite, weight loss, inability to sleep, sometimes a low fever, sometimes feeling low or depressed, which is common with lots of chronic conditions, and systemic problems. So what I mean by that is other problems which affect other parts of your body, not just your joints. So sometimes people with rheumatoid arthritis can experience eye problems, heart problems, things like that, which is why it's so important that people are under the care of a rheumatologist, because they'll be well used to seeing people with those issues. So diagnosing rheumatoid arthritis is not particularly easy. It relies on putting together lots of information. So history, getting the history from a patient, examination, having a look, to see what's going on. Some blood tests are useful. There's a range of blood tests that are normally performed. Probably the most useful one in that list is the anti-CCP antibody test, which basically is quite specific for rheumatoid arthritis. All the other tests there are not very specific. So things like ESR, CRP, those tests can be raised in for lots of different reasons, whereas the anti-CCP test is pretty specific for rheumatoid arthritis. The unfortunate thing about that test is people can have a positive anti-CCP test, but still, have a negative anti-CCP test and still have rheumatoid arthritis. So some imaging might be useful as well: X-rays, MRI, ultrasound. So the treatment for rheumatoid arthritis is an early rheumatology referral. That's probably the most crucial thing here, as I mentioned before. The earlier someone gets to see a rheumatologist, the better their outcome will be. So it's important that a clinician does recognize it, or even if they suspect it's rheumatoid arthritis, they should make the referral. The problem is that some parts of New Zealand, it's quite difficult to see a rheumatologist, particularly if you live outside a main centre. So that can be an issue, getting seen early and getting regular follow-up. But those are really key things if you have rheumatoid arthritis. So some of the treatments are painkillers. So usually most forms of arthritis will cause some sort of pain. So these painkillers are common to managing most forms of arthritis, whether it's rheumatoid or osteo or gout arthritis. And they can range from quite mild painkillers like paracetamol and work their way up through stronger painkillers. Generally, the stronger the painkiller, the more side effects you might experience. The other drugs that are used are the non-steroidal anti-inflammatory drugs, or NSAIDs. And you're probably familiar with some of these, things like celecoxib or naproxen, ibuprofen, diclofenac sodium, those things. They are all useful. They can control inflammation and therefore control pain. The problem with them is they have got some quite significant potential side effects. So people need to take those with care, and usually clinicians will prescribe them with caution, because people can develop quite serious side effects from those medications. Corticosteroids, the good thing about corticosteroids is they tend to work quickly and can be very effective in reducing inflammation. And they can be used as either oral medication like prednisone, or injections into a joint, or injections into a muscle. So there's a range of ways that people can receive a corticosteroid. And then these specific drugs, these disease-modifying anti-rheumatic drugs, or sometimes abbreviated to DMARDs. So this is what rheumatologists are very expert in, is the use of these medications. They'll have lots of experience in using them. And you're probably familiar with some of these. These are things like methotrexate, sulfasalazine, hydroxychloroquine, which has received quite a bit of press recently because of the possible link with treatment with COVID-19. I think that's actually been proven. So leflunomide, I think I mentioned that before. There's quite a few disease-modifying anti-rheumatic drugs out there, which a rheumatologist will have experience of. And usually, the problem with those DMARD drugs is that they tend to work slowly. So if people are starting on something like, for example, methotrexate, they may not see any response for weeks or months before they know it's effective or not effective. And it can be quite frustrating in trying to find the right combination of treatments or treatment for somebody. And then the last thing on the list is the biologics, which have really revolutionized rheumatology in the last few years. These are relatively new treatments, and the great thing about biologics is they work quickly. If they're going to work, they tend to work a lot quicker than the older DMARDs. They are incredibly expensive. They're very complex treatments. They take a lot of research has gone into developing them. They're quite difficult to produce. They use molecular biology to produce them, hence the name. Incredibly expensive. But if people fit the criteria, then there's no charge for the patient to be on a biologic. But the problem is getting onto a biologic is usually you have to exhaust all the older treatments first before you get onto a biologic. Because most people will not need to be on a biologic because the older treatments, less expensive treatments, will work quite well for them. But biologics are there for people who either don't respond to the older DMARDs or the older DMARDs cause them too many problems. And a rheumatologist will have good experience of using biologics. So this is one of the questions that was raised at the last webinar we attempted to do, was what's the difference between DMARDs and the biologics? And apart from the cost, it's the way they work. Biologics, tend to work on what we call inflammatory cytokines. These are things which drive inflammation. And what has been possible is it's been possible to identify some parts of that mechanism and actually selectively block some of that inflammatory response. So that's what biologics have been designed to do. Problem is that in New Zealand, we've got a limited amount of biologics that are funded by Pharmac. If you went overseas, you might find that you get better access to some of those biologics, but it's something that we're always mindful of, trying to make access to these medications a bit easier for people in New Zealand. So there are some non-drug treatments as well: exercise, relaxation techniques, diet, sleep. Omega-3 supplements can be useful. Probably the best way to get omega-3 is through your diet, though, rather than buying a supplement if you can. Occupational therapy and assistive aids. So these are all other ways, in addition to medication, which can be helpful for some people. So looking at exercise in particular, why exercise? Well, helps us to keep our muscles strong, to support our joints, can help with weight loss, and there's lots of social benefits as well to exercise. Obviously, at the moment with our COVID-19 restrictions, we're a bit limited on what we can do, but there are some exercises that people can do at home, and obviously, we're still allowed to go and exercise locally at the moment. Some types of exercise which people report as helpful. So physiotherapy is fantastic. Obviously, those physiotherapists out there are the experts when it comes to exercise and can give you a specific exercise program targeted for you. Walking is great because it's nice and convenient for most people. Tai Chi, which is like a slow, controlled martial art. Water-based exercise. Water is fantastic for people with arthritis. It helps to support your body weight, gives you some resistance to move again, so that can be really fantastic if you can access a water-based exercise program. Cycling, yoga, particularly hot yoga. Some people say this Bikram yoga is very beneficial for rheumatoid arthritis. Green Prescription. Some of you may be familiar with Green Prescription. This is a free exercise program that you can be referred on by your GP or your practice nurse, and it's a nationwide program. The key thing with that exercise is really you need to enjoy it, because if you don't enjoy it, you're probably not going to continue with it. Some relaxation techniques can be very helpful, managing any chronic condition really. So things like massage, deep breathing, mindfulness, guided imagery are all examples of some relaxation techniques that people can find out about. Distraction can be useful. Just taking your mind off your symptoms and focusing on other things can be very helpful, particularly for short-lived sort of activities where you've got to do something which you might be uncomfortable. A distraction technique might be useful. So an example of a distraction technique would be to count backwards from 100 in threes. So, trying to subtract 3 from 100 takes a little bit of effort. Well, it does for me anyway. Sleep. Sleep is really vital. It affects our physical and emotional health, and it's restorative. So what we do know is that if you're having sleep disturbances, it can make all your other symptoms worse. So it's really important that people try and maximize the possibility of getting a good night's sleep. And there are some things that people can do to make it more likely you will get a better quality sleep, and that's covered by sleep hygiene. Sleep hygiene is a term used to describe all the common sense things that people can do to make it more likely you will get a better night's sleep. So things like making sure your room is dark and the temperature's okay, and that you haven't got any distractions in your bedroom, like devices, computers, TVs, and the like. Making sure you don't drink caffeine before going to bed. Making sure you get some exercise during the day. All those things make it more likely. Don't guarantee you'll get a good night's sleep, but make it more likely. So diet, the link with diet and rheumatoid arthritis, I think, is fascinating. Lots of papers published on the possible links with diet and rheumatoid arthritis. This is just one I've put there, but this is a really great one. I like this one because if you read the entire paper, it gives you lots of additional papers you can go and have a look at to see what's been studied when it comes to diet and rheumatoid arthritis. So there does seem to be some reasonable evidence that making some dietary changes might have a positive impact on your rheumatoid arthritis. So this is an article you might want to read. This is also something that you might want to have a look at. This is called the Paddison Program. I don't know if you've heard of this already, named after this guy, Clint Paddison, who put the program together based on his own experience of living with rheumatoid arthritis. He found that from making some dietary changes, he could actually have made a huge benefit with his own rheumatoid arthritis. He was taking the medications from his rheumatologist, but found that actually changing his diet also made a difference. And based on his own experience, he's put together this program, which has now become an international program. Many people can follow it, and it seems that people who go on the program generally do quite well. But obviously, when you go on this website, you'll only hear the positive stories. I'm sure there are people who've tried this program and found it not to be so helpful. But you can say that about any treatment, really. So something that you might want to check out. If you Google the Paddison Program, you'll find out all about it. It's certainly got some detractors out there. There's this, if you Google Paddison Program, you'll come across this as well. This is what looks to be like a scientific article, basically debunking the whole program. But when you read it, you'll realize it's actually just one guy's opinion. It's a guy called David Gorski. So you might see, I'll put my little cursor on it there at the bottom. So this is basically just one guy's opinion based on just watching a TED talk by Clint Paddison, I think. So he reckons that the reason Clint Paddison improved with his rheumatoid arthritis is because he went into spontaneous remission, which can happen sometimes.
and also that Clint Paddison's rheumatoid arthritis wasn't that bad anyway, which if you look a bit deeper, you think that, well, it probably isn't true, because Clint Paddison actually had to have a synovectomy, which is usually a sign of pretty aggressive rheumatoid arthritis. He also has had lots of other people using his program reporting that they do feel some improvement. So that's unlikely to be spontaneous remission for all of them, I don't think. But anyway, I think it's worth looking, exploring this and making your own mind up about it. So another field which I think is really interesting is the idea of using parasites to try and manage autoimmune condition. So this is something called Helminthic therapy, which is basically using parasitic worms to try and manage autoimmune conditions. So I think this is fascinating. I think the idea behind it is that our immune systems have evolved with us alongside these parasites, which have lived with us for a long time. And now we've successfully managed to get rid of a lot of these parasitic infections. Our immune systems start to behave abnormally. So that's the theory behind it. And so people have taken that theory and flipped it on its head and thought they could treat autoimmune conditions by using parasites. And there seem to be some fascinating studies to support that might be the way forward, but they're still pretty much in its infancy. People can actually go and infect themselves with a parasite if they want to. You can buy this stuff online, but we certainly wouldn't advise you to do that without checking with your rheumatologist. As with any new treatment, any treatment that you want to think about, any new treatment, we would say discuss it with your rheumatologist, discuss it with your GP, discuss it with your pharmacist first, because we want to make sure that these things are safe. And but I think it is fascinating. I think people, there is lots of literature out there for people who want to find out a little bit more about it. So there is help, obviously, available for people with rheumatoid arthritis. GP is your first point of call for any health issues. Hopefully, you'll be under the care of a rheumatology service and get regular follow-ups. Pharmacists are great out there in the community. They're free advice from a pharmacist. Talk to you about medications and supplements and the like. Occupational therapy. In an ideal world, rheumatology clinic would have alongside them an occupational therapy service, a physiotherapy service as well, because those allied health professionals can be really helpful in helping you to manage some of the aspects of living with rheumatoid arthritis. Podiatrists, very helpful. Lots of people with rheumatoid arthritis get problems with the feet, so seeing a podiatrist may be a good idea. Dietitian, if you want to look into the dietary aspects of managing a condition like this, and Arthritis New Zealand. So we have got our resources which are available for people. There are some support groups out there. So these are Facebook support groups, and you'll see at the top there is a support group for people with rheumatoid arthritis. So the links are there. We have our website. So this is just a snapshot of one of the pages on our website, particularly around the arthritis and COVID-19 response. Lots of questions about whether people with rheumatoid arthritis should continue taking medication. The advice generally is yes. Most rheumatologists would say continue to take your medication. The risks of taking your medication are small compared to the risks of not taking medication, because we know that some of these medications can be immunosuppressive. You'll see that on our website there's our Donate Now button at the top there, so we do encourage people, if they're able to help support our organization and delivering webinars like this and presentations. We rely on funds from donations and the like to continue to provide our services. So those are our contact details there. We have got 3 offices in the country. We've got one in Auckland, one in Wellington, one in Christchurch. Obviously, at the moment, during the COVID-19 lockdown, these offices are closed, but our 0800 number is still available, and you can anybody can call that 0800 number. It's a free call from anywhere in New Zealand, and you can talk to one of our team. We also have a website, which the address is there, and also an email address where you can send questions to. So info@arthritis.org.nz. So there's a reference about the obesity. Normally, if we were running a webinar now, we would ask for questions. Obviously, this is being pre-recorded, so but please do post your questions. Please do call our 0800 number and talk to one of us. So we're here to help. So I'll sign off, and thank you very much for listening.